Good evening, everybody. Welcome to the Cardiological Society of India Cardiac Rhythm Council Digital Summit of 2020. This happens to be the last day and a very, very special day for me because the speakers who have consented to be presenting to all of us are of an extraordinary caliber. Their contribution to the country has been enormous. Many of them are from India and some of them are from outside the country. We are going to be beginning with one of our close associates of the electrophysiology education program, and that is Rajiv Kumar Pathak, who happens to be the director of cardiac electrophysiology from Canberra Hospital from Australia. But even from the Australia, he's helped the progress of the education regarding the electrophysiology in India so tremendously. There are several of the junior EP minds have been trained by him already. Some of them are getting trained, including our own Dr. Deepchand Raja is there with him. So to start off the final day of this Cardiac Rhythm Council Digital Summit, we have KK Mohan Nair, one of the brightest of the minds of the electrophysiology field in India, a prolific author of the electrophysiology field, is going to be leading this particular session, the first session, who is going to be ably assisted by Deepak Padmanabhan, another a young star of electrophysiology from Jayadeva, and Avinash Verma, our dear friend. These people are going to take up the first session. So welcome, Dr. Rajiv Kumar Pathak from the Cardiology Society of India, Cardiology Society India, Chennai chapter. We are very privileged to have you. And Dr. K. Nair, please take over the session. Thank you.
Thank you, sir. Good evening, everybody. So Dr. Rajiv Kumar Pathak is well known to everyone and he doesn't need any introduction. It's a great honor for me to invite Dr. Rajiv Pathak, who is a clinic academic and lead of cardiac electrophysiology at the Canberra Hospital, Canberra, Australia. He's also the head of the Heart Rhythm Disorders Research Group at the Australian National University. Dr. Pathak is trained by two eminent electrophysiologists, Professor Santers at the Royal Adelaide Hospital in Australia and Professor Wachinsky at the Hospital of University of Pennsylvania, USA. Dr. Pathak has received many honors, including the Young Author Achievement Award by the American College of Cardiology in 2016. Of the last 10 years, he has made significant contribution to the literature in the field of electrophysiology with more than 1,500 citations. Dr. Pathak is committed to continue making contributions as an educator. He has established a electrophysiology fellowship program through collaboration with the Australian National University and the Canberra Hospital. Dr. Pathak has been recognized as an emerging leader by all the major cardiovascular societies such as American College of Cardiology, American Heart Association, and the Heart Rhythm Society. I hereby invite Dr. Pathak to take over the platform and enlighten us on non-outflow tract idiopathic ventricular tachycardia. Dr. Pathak, please.
Thank you, Dr. Ulas and Dr. Mohanty, Dr. Padmanabhan. It's an absolute honor for me to be presenting in this forum. And I really want to thank Dr. Ulas for this kind invitation. It's always very special to do anything associated with Triple M and with Dr. Ulas because of the friendship, but more so because of our ongoing collaboration between us. With that in mind, we'll start with our presentation. The topic of today's discussion is about non-outflow tract ventricular tachycardia. And basically, I'm not sure if the slides can be seen. Let me share the screen, guys. Can everyone see my screen?
Good.
Yeah, wonderful. So today's topic, I want to discuss about the non-outflow tract ventricular tachycardias. It's a really broad topic, and basically, I like to initially concentrate on intracavitary structures. When we talk about non-outflow tract VTs, we really talk about intracavitary structures and arrhythmias coming from those areas, and also epicardial structures such as crux or true epicardium. Because of the time constraints, I like to concentrate on intracavitary structure so that we can really do justice and talk about some of the intricacies and how to be able to identify these arrhythmias and successfully ablate these arrhythmias. Premature ventricular contractions, in addition to causing potentially debilitating symptoms, can cause significant LV dysfunction. Multiple single-center studies have shown that catheter ablation is often an effective treatment strategy and for cure for these. However, catheter ablation of PVCs originating from endocavitary structures such as papillary muscles and epicardial structures such as crux or the true epicardial myocardial structure itself remains challenging compared to PVC coming from areas such as outflow tract or cusp region. Shown in this slide is the pooled data from 8 centers. One of the speakers later on in the session is involved in one of the study, Dr. Kumar Sham from UCLA. He is involved, and one of out of those 8 centers, one of the center is from UCLA, basically looking at the data from PVC from different areas. As we can see, the acute success of PVC ablation may be acceptable. The long-term outcome data are generally sobering for these cases and often requires antiarrhythmic medication for some reasonable outcome, especially in these cavitary structures. As we can see here, the papillary muscle represents the green bar and the purple represents the PVCs coming from crux and epicardial area. More importantly, the procedural duration, the fluoroscopic time, and the radiofrequency ablation, all of them are significantly greater for PVCs coming from the papillary muscle and epicardial in comparison to those coming from outflow tract region. When we talk about these endocavitary structures, we are really talking about the PVCs which are coming from posteromedial papillary muscle, the anterolateral papillary muscle in left ventricle, and in septal RV, we're talking about the moderator band and anterior papillary muscle and septomarginal trabeculations. So these are the real areas where I'll be trying to focus my talk on today. When we talk about these PVCs, this is the traditional, or what should I say, the textbook ECG changes which we normally see in the anterolateral papillary muscle PVC. These are PVCs which will have right bundle morphology. They will have inferior axis. Mind you, most of these PVCs not necessarily will have lead 2 being positive, and it all depends on where the anterolateral papillary muscle is inserted. You might see either a positive, negative, or negative in lead 2, but lead 3 always remains positive. When you look at the lead 1, you can have a small R wave followed by S wave, or can be a significantly deeper S wave seen, and that will be marker of where the PVCs are preferentially exiting towards the septum when the R wave will be more there, or it is predominantly exiting from the lateral side when the you normally see more of a deep S wave. When it comes to the posteromedial papillary muscle, we see a right bundle morphology again. This time we have a superior axis. And again, in these patients, invariably, in these PVCs, you will always see a S wave in lead 2 and lead 3. Presence of R wave versus S wave depends on, again, which direction the PVC is exiting from. If it's septal exit, you'll see a R wave in lead 1. And if it's preferentially a lateral exit, in those patients, you will see a S wave. When it comes to RV papillary muscle PVCs, we normally see left bundle branch morphology. Superior or inferior axis depends on various different papillary muscles, the structures, and where these PVCs are preferentially exiting. Papillary muscles of the heart are complex intracavitary structures. They have various shape and sizes, which can be highly variable, and so as their subendic endocardial vasculature and the Purkinje connections, which are normally seen in this. Anatomically speaking, the papillary muscles of the heart are the thickest myocardial structures in the heart and comprise a complex of myocardial strands with some separation between them at the basal and at the apical regions. This likely results into the anisotropic conduction. These anatomical variations have a considerable influence on the arrhythmias and the challenges we face in the ablation. I'll be highlighting some of those as we go on in the presentation. When we look at these ECGs, while most of the ECGs can be straightforward, but if you pay attention, you'll be able to see some of the findings which can tell us about the substrate and also the challenges which might be involved in the management of during the mapping and ablation. If you look at these PVCs, they can have a right bundle morphology. However, the R wave becomes S wave anything between from V2 to up to V5. So you can have an early precordial transition or a late precordial transition. You could also see these notchings, which can suggest that you have scarring, and this can be a scar-related PVCs in those patients. Again, it is important to pay attention to some of these ECGs where you can see either it is slightly less inferiorly directed versus deeper S waves can be seen, all suggestive of a variable exit, and which could be very challenging. And it's important to note this before the start of the case. You can be mentally prepared that this might take longer than what is usual. Or you can see this coupling, which is not very uncommon to see when these PVCs can have a inferior and superior and inferior axis which are coupled, maybe suggesting that the site of origin might be deep intramural and having a preferential exit in both the directions. There are various isolated factors which have been identified in various previous series which can predict the outcome of ablation. Presence of pleomorphic PVC, as I was talking about, could be a negative predictor of outcome, whereas activation time and a perfect pace match can be a positive predictor of a good outcome. Similarly, increase in papillary muscle size or lesion can be an adverse predictor of the outcome. Let's go through some of these and see how some of these can be utilized for mapping. Now, when we talk about the planning for an ablation of these PVCs, it's important for us to do a pre-procedural planning. A good ECG, looking at the holters, so that we can understand if there are variable exit, if there is a variable precordial transition which is seen, which can really tell us that these cases might be very difficult. A good pre-procedural imaging, which helps us to understand the substrate we are dealing with, doing an echocardiogram or CT and MRI. And we always in our lab use those for image integration with a 3D map, which can help us to try and ascertain the real exact spot where this might be coming from. In vivo use of intracardiac echo is almost must in these cases, which can help us to, one, diligently map the areas and also do an ablation and be confident that the catheter is in the contact with the tissue which you're mapping. Various different techniques can be utilized for mapping using activation and pace map, and I'll go through that. And it's extremely important to use a force sensing catheter because being an intracavitary structure, it's important to maintain a force contact, and using a forces vector can help us, enable us to make sure that you are in real contact with the tissue. Now, it's important to use multi-imaging modalities such as cardiac MRI with the real-time imaging data from intracardiac echo to help and identify the different size, various shapes, and the sites of origin of PVC. And this can enable us to better understand the underlying anatomical substrate. This could also help us to understand the electrophysiological changes which are seen during mapping and ablation of these PVC. So if you see a papillary muscle which has got bifid shape as the second slide here shows, and if there is a deep intramural PVC, this could explain the coupling of inferior and superior axis PVCs which are seen at the same time. Whereas if you see a scar, then you understand this may be a scar-related PVC we are dealing with. One of the greatest challenge in mapping and ablation of these PVCs are the difficulty in maintaining the catheter stability. As you can see in this image, which is an intracardiac echo image, despite a real-time imaging, it is sometimes extremely difficult to maintain a catheter stability, and therefore it is difficult to not only map but also to ablate in these regions. Additionally, considering the papillary muscles are the thick myocardial structures, and the origin of these PVCs may be located deep intramural or sometimes epicardial surface with preferential exit, it is difficult to ascertain the true local EGM during mapping. Now, I'll try to show a couple of cases, but most importantly, we understand activation map is the most reliable method for mapping these cases. The variable intramural depth of these origin of these PVCs and the variable exit may explain the controversies which exist in the utilizing of these pre-potentials, what we see, and the potentials we map during the case. So there are two papers which have come through, one of them showing the importance of pre-potential, while the other one, there was, the pre-potential was not, finding the pre-potential at the early spot was not necessarily associated with a good outcome. So let me share a couple of cases with you. So this is one of our case where we have a patient with a posteromedial papillary muscle PVC, and we went on to do a mapping of this posteromedial PAP, as you can see the structure. We mapped a different region, and these are the EGMs which you can see. At the site A, we see this sharp potential, which is clearly early. As we move towards the base of the papillary muscle, we saw a far field potential, which was far earlier than the sharp potential, which can be seen at the site A. At the site C, which is the deep intramural at the base of the papillary muscle, we see an extremely early signal. However, it's a far field looking. The first question which arises, which one is the best spot where you're going to ablate? Clearly, our understanding shows that where is the sharpest signal should be the first target. Of course, we also did so, and we ablated in the spot. We had a good pace map, and in spite of doing an ablation in that spot, we really found that the PVC did not eliminate. We found the PVC had a slightly different morphology this time, suggesting that there was a variable exit. And to eliminate this PVC, we really had to go to site C and site B, deep intramural around the base, before we could manage to eliminate that PVC. Similarly, there are sometimes we see challenging cases where activation map on both sides of the papillary muscle could be similar. In this anterolateral papillary muscle case, what we see here is that on the anterolateral papillary muscle, once you do an activation map, both the septal side and lateral side of the papillary muscle had similar activation time. In fact, in this case, we had to draw what we suspected was that the PVC was coming from deep intramural origin and basically had equal preferential conduction on both sides of the papillary muscle. In this particular case, we almost had to draw a line around that papillary, both septal and lateral side, for us to be able to eliminate that PVC. So while activation map is useful, there are challenges involved in doing an activation map of these PVCs, and sometimes you might have to map extensive and cover the whole area rather than a spot ablation. Similarly, while activation map is useful, one of the distinct electrophysiological finding of papillary muscle PVCs are that they can have multiple QRS morphology. These QRS morphology can be subtly different, either spontaneously or could be after the initial ablation lesion. Now, this could be either because of the deep intramural origin of this PVC and they are preferential exit. And when you eliminate one of the preferential exit, these PVCs then start having elimination, they start coming out from a second spot or a second preferential exit, and therefore they have a changing morphology. In these patients with changing morphology, work from a Yamada group and colleagues have looked at the latency of post-pacing interval and found that ablations are often successful at the site with the pace map with a greater latency. So if you see a site which where you have a good pace map, Not necessarily that's a site of origin. That might be site of exit for those PVCs. And when you manage to capture and there is a latency, that might be the site of origin from these PVC. Let me again show a case. So this is a case of a patient who has a bifid, large anterolateral papillary muscle, with a big septal and a lateral head. In this patient, we basically went ahead. We have a anterolateral papillary muscle PVC with the right bundle morphology, no transition, inferior axis, and negative in lead 1. Now, this does suggest that this one has a lateral exit. We started the case with using the image integration and real-life echo imaging and mapped the septal head of the papillary muscle. What we see is an early prepotential, which is minus 26 milliseconds. A pace map at this spot did show a reasonable pace match of around 86 to 90%. However, the stim to QRS was 28 milliseconds. We went ahead and then did a map of the lateral head of the PAP muscle. At this spot, we found the potential to be even earlier, and there was a 44 millisecond ahead. What is more interesting here is to see that pace map at threshold was 92% pace match, and with stim to QRS was also prolonged in this region. Ablation in this spot finally led to elimination of the PVC, and as you can see, the catheter is on the lateral head, and we managed to eliminate that PVC from that spot. A lot of questions do come whether we should do a retrograde ablation or an antegrade ablation approach. There are, while our center, we preferentially always start with retrograde. However, there are a lot of centers who will initially go for a retrograde approach for posteromedial papillary muscle and do an antegrade approach for some PVCs which are coming from the posteromedial papillary muscle region. And I don't, it all depends on how the structures are. And personally, I like to look at the imaging, look at the CT or MRI, understand the relationship of the papillary muscle to the myocardium, and based on those, we make a decision about which will be the best approach for these PVCs. And I might go retrograde or antegrade based on what the structure looks like and how the anatomy or the papillary muscle sits in the LV myocardium itself. One of the last things which is extremely important, I want to really emphasize, will be when you are doing ablations of these PVCs, it's extremely important to use an irrigated ablation catheter, because lesion application, especially considering these are deep intramural, it's important to try and have a deeper penetration. Using a force sensing catheter with the vector is again important, which can help you to enable the direction in which the force is applied. Use of real-time imaging is important. And also sometimes, despite all of those, there will be failure because of the poor catheter stability. And in those cases, I think use of cryo is extremely important, which can help us to get a stability. I'll move on from there quickly to right ventricular intracavitary structure. If we think the left ventricle is complex, right ventricle unfortunately can be equally complex, and in some cases, in fact, turn out to be more challenging. The structures here which are responsible are the moderator band, the anterior papillary, and the posterior papillary muscles, which of the right ventricle itself. So I'll try and take you through the case. Before doing so, I like to show a couple of ice images which can really highlight the complex structure sometimes you're dealing with. This is the case me and Deep did, I think last month, where we had this patient with incessant PVC coming from the right ventricular papillary muscle region, and we found this complex myocardial structure with the moderator band, the anterior papillary muscle. And invariably in these cases, we always use multi-imaging modalities to create the 3D structure so that we can understand the anatomy before the start of the case. So this is a 33-year-old male who has ejection fraction which was preserved initially, but really reduced by the time he came to see us. His PVC burden was around 30%. He had a couple of attempts in outside hospital, and this is the PVC morphology. We have a left bundle very late transition. We have a superior axis with positive in lead 1, suggesting this is the right ventricle coming from the basal basal region. AVL is positive, suggesting it might be somewhere near the free wall region we are dealing with. So we went ahead. At that stage, we were doing trial of this Cardiolnsight, a non-invasive 3D mapping system, and we wanted to utilize this because this was a couple of times this patient was already attempted, and we wanted to see if this ECGI system could pick up where the spot was. Just to orient the viewer, this is a tricuspid annulus, and the ECGI mapping or the Cardiolnsight mapping did suggest that this was coming from RV free wall of the tricuspid annulus. And this is the activation map using the ECGI. We went ahead and did an activation map of this PVC, and this was found to be coming from exactly where the Cardiolnsight suggested it will be coming from, on the RV free wall of the tricuspid annulus. The earliest spot was 32 millisecond pre. The pace map was also very reasonable in this area, and at threshold, we almost got a 12 by 12 match. Ablation lesion was performed, and as we discussed, it's important to note in this region, if you are using an ablation catheter, it's good to use a sheath, especially a large curl sheath, so that you can cross the tricuspid valve and you can sit in the right ventricle. And then we used an ablation catheter with a C-curve, really showing where the direction of the vector is, and ablation lesions were performed in this region. This is the real-time echo image showing the catheter contact. What I like to really show that to the viewer, that as we can see, the catheter stability remained a challenge in this region when you're trying to do a catheter ablation. Anyway, ablation was performed, bunch of lesions were given. We mapped multiple times, and despite giving a lot of lesions there, the PVC persisted. The options for us were to try and use higher power. We were already going 40 volts. I'm not sure how much we can really deliver more power there, using half irrigated saline or doing endo-epi sandwich lesion. We decided to go epicardial. We use a DECA-NAV to map the epicardium, and we basically had an ablation catheter in the endocardium and a DECA-NAV in the epicardium, and we did a simultaneous mapping. We did, of course, did a coronary angiography to look and delineate the coronary arteries around this area. So in the epicardium...
I'm extremely sorry for the interruption. 2 minutes of the screen time left, sir. Thank you.
So we had beautiful signals which can be seen on the epicardium in this region. Ablation lesions were performed. Again, I would like to really draw attention of the viewers when you are doing an epicardial ablation, is to make sure that the vector is facing towards the endocardium rather than the epicardium. Otherwise, you'll be wasting a lesion. You will not be delivering myocardial ablation. It'll be ablating the pericardium itself. Anyway, ablation was performed. Despite ablation from epi and endo, the PVC continued. So what are the options? At this stage, as I told, I would like to draw attention of the viewers to this, the ICE image, which does show us why we did not manage to eliminate this. One, because of the thickness around this area. Number two, the septal leaflet itself was preventing us to be able to deliver the lesions around this area. So with that in mind, we decided, can we try and go from the jugular approach and get to this area? And that's what we did. We went from the neck. We used a short edgeless sheath. We managed to go there. And this ICE image shows an excellent catheter contact. And we managed to find the early signal, and ablation lesions were performed with complete elimination of the PVC from this region. So I'd like to quickly draw attention towards the strategies which should be utilized in patients if you are suspecting a right ventricular PVC. Use of a large sheath, use of an intracardiac echocardiogram, and sometime again, if you fail, especially in moderator band cases, use of cryoablation should be utilized. So the take-home message is ablation of papillary muscle PVC is safe and effective treatment strategy. Ablation remains challenging because the origin of these can be deep beneath the endocardium of the PAP. They often have multiple curious morphology due to preferential conduction. Pre-procedural cardiac MRI and in vivo intracardiac echo can be helpful to assess the substrate. The alternative approach of a transseptal for LV anterolateral papillary muscle, a jugular approach in case of RV subannular VTs, or a cryoablation should be utilized in difficult cases. Or if the pre-procedural imaging suggests that those should be the best approach, they can be utilized as a primary method as well. Thank you very much for the attention.
Thank you, Dr. Rajiv Padak, for the wonderful and excellent presentation. Dr. Deepak, you want to?
Avinash, you can take it. Avinash.
Yeah. So that was a beautiful talk. So I must say, and I was even more pleased with the amount of good cases that you saw, that you showed. One thing I would like to talk that with the benefit of Carto sound that you have there, I saw that you used in nearly every case. So
Yes.
do we have anything or any alternative approaches which you would like to suggest, because many places in India might not be having such kind of technology?
So look, there are a couple of things which can be utilized. Let's talk from simple basic thing. A good echocardiogram so that you can understand the structures. A good even transthoracic echo should be able to show you if there is a bifid papillary muscle, where are the structures. Number two, you can use a transesophageal echocardiogram during the procedure itself, and you'll be able to see these structures. Then either CT or MRI can be utilized to understand the anatomy, and then utilization of those along with ECG. While we have luxury of these, if you look at the pacemapping case, we had a right bundle morphology, V4 transition, truth being positive, lead 1 negative. It did tell me already that this papillary muscle PVC is exiting more laterally. Now, unfortunately for these particular cases, unless you have a real-time imaging, it is very challenging. It is nearly impossible to be 100% sure, are you in contact with that particular structure or not? So trying to use imaging, maybe not Carto sound, maybe just an ICE image, just to be able to see at least you are in contact with the tissue is important. So either using a transesophageal echo if you have a cardiac anesthetist who can help you, or using just an ICE will be something really important in these intracavitary structures at least.
So we have a question from Dr. Deep. Ablation strategy for deep intramural lesions.
So yeah, they keep pushing me to use half normal saline. And that's why he's asking me this question. It's a use of, we can do multiple different strategies. So either you can use high power and you can try a longer lesion. So instead of using a 60-second lesion, doing a 2-minute or 3-minute lesions can be given. You have to be really careful. You need to have real-time imaging and to be able to see if the lesions are formed safely because of the risk of steam pop. Anything more than 2 minutes, the risk of steam pop is significant. Number two, when you are jammed into these papillary muscle, the irrigation can be low because of the less blood flow around, and the risk of steam pop is very significant. Number two, you can use half normal saline, which has been used by Dr. Zado's group and all these people, and Dr. Sadak's group, they have done that. So that can be utilized. Number three, simultaneous unipolar ablation can be performed. So you have endo and epi, and you are using simultaneous unipolar, or bipolar ablation can be performed. So those are the 4 different strategies which can be utilized.
Are formed safely because of the risk of steam pop.
So these are the 4 different strategies which I will utilize.
So I think we have one more question here. Okay. So why papillary muscle and moderator bands are vulnerable for genesis of PVC? And with that, if I may add just one more question. While ablating either on the fibrous end or the tip of the papillary muscle, or giving a circular lesion around the base of the papillary muscle, particularly in the posterior medial area, have you faced any problem with the structural or the functional parameters of the LV in follow-up?
So that's why it's extremely important to define the structure. And we always tell our fellows, map, burn in your brain before you burn the tissue. So 2 hours of mapping and 10 minutes of ablation is much better, so that you have defined the spot and limited number of lesions to be delivered in those areas. Of course, there is a small risk when you are doing an encircling ablation around or isolation of the papillary muscle. You can cause rupture and can cause regurgitation. I strongly discourage papillary muscle isolation and ablation around those papillary muscle. As you can see, we do try to limit number of lesions required to be able to eliminate those PVCs. Of course, there is a small risk there. In our series, we have not seen any significant increase in valvular dysfunction, but we limit number of lesions we try to give in these cases.
All right. So, Rajiv, on the occasion of Teachers' Day and on behalf of Cardiological Society of India, let me express my gratitude. You have been a wonderful teacher of this particular arrhythmia issues. I think what is important for us is our outflow tract tachycardias. I think the conventional fluoroscopy, maybe, not much of an effort is required, but when it is non-outflow tract tachycardia, and if you really have taken up the patient to relieve their symptoms, or sometimes you actually do it even though they are not symptomatic because you are thinking the frequency is more. What we got to do is you got to handle them only when the imaging system, and as you said, you burn your brain so very much. Are you very well equipped to deal with this? I think you conveyed this message so very well. And we are all inspired by your work. And every time we visit us, it is such a pleasure. And we want you to be collaborating with us and make, the EP team of India much, much better. I remain grateful to you from the behalf of Cardiologists of India. Thank you very, very much, Rajiv.
Thank you very much. Thank you, everyone. It has been an absolute pleasure to talk to you guys.
Next issue here, and this is a day-to-day problem. We are kind of interested to convert, sometimes quickly the atrial fibrillation into sinus rhythm. So we have Vikas Kataria, an expert in the arrhythmia therapy from Delhi. He's associated with Dr. Mohan Nair, a big figure of cardiac electrophysiology in the country. So to take up that particular session of pharmacological conversion of atrial fibrillation, I have Joseph Theodore. I'm so closely associated with him. He was there with us here in Madras Medical Mission. He's a professor now at the famous Jipmer Center at Pondicherry. They do a lot of work in arrhythmia. Joseph will be ably accompanied by Rajesh Sharma and most importantly, the joint organizing secretary of this summit, my dear friend Pratap Kumar. So over to Joseph. Welcome Vikas Kataria and take over the session. And so good to see you.
Yeah, thank you, sir. It's first of all, I need to congratulate Ullas sir and CSI Chennai for organizing such an academic feast every evening throughout this week. So, without much ado, it's my pleasure to introduce Dr. Vikas Kataria, who's a well-known IP figure in our country, and he's been associated with stalwart like Dr. Mohan Nair. He finished his fellowship in Belgium and has been doing lots of works. and he's got lots of awards and publications under his name. So I request him to deliver his talk on pharmacological conversion of atrial fibrillation, which is a very common frequent arrhythmia, which has been very severely undertreated in our country. Please, the stage is yours.
Thank you, Doctor. So, good evening, dear moderators and my dear colleagues. As rightly said, there are certain indications in certain situations where we may have to convert an episode of atrial fibrillation into sinus rhythm. For this purpose, the two modalities available to us are either electrical cardioversion or pharmacological cardioversion. Electrical cardioversion is much more faster and much more effective than pharmacological cardioversion. So this becomes the modality of choice in patients who are hemodynamically unstable. But it causes a lot of discomfort to the patient, whereas pharmacological conversion, on the other hand, is a less effective, slower process, but it's much more convenient to the patient. So today, we're going to discuss about the pharmacological conversion of atrial fibrillation. So the symptoms in majority of the cases of AF are primarily because of fast ventricular rate. And the method by which we can control, we may control the ventricular rate is either by using the AV nodal blockers to decrease the ventricular response. This is commonly known as the rate control strategy. Or the second method of controlling ventricular rate is to convert AF into sinus rhythm, which is commonly referred to as the rhythm control strategy. Theoretically and logically, it appears that converting AF into sinus rhythm is much better than controlling just the rate. So the list of benefits with the rhythm control is long, but despite this long list of benefits on achieving sinus rhythm, the majority, almost all the trials, which were all the large major trials which compared rate control strategy versus rhythm control, none of these trials actually showed superiority of rhythm control over the rate control. Whether we take the mortality or we consider event-free survival, on both the accounts, rhythm control strategy failed to show any superiority over rate control. But despite these not so encouraging results, many of us, we still believe that achieving rhythm control, achieving sinus rhythm is much better than by just controlling the ventricular rate. So therefore, many of us actually give at least one trial of achieving sinus rhythm in almost all patients, or at least in selected patients of atrial fibrillation. And for those of us who strongly believe in rhythm control, there is a good news. Recently, last week, there was one study published in New England Journal. And this study called East AFNet 4, in this study, approximately 2,700 patients, they were randomized either to the early rhythm control arm or to usual care. And for a change in this trial, the rhythm control was found to be better than usual care. The cumulative incidence of death, stroke, and heart failure admission, that was much lower in rhythm control compared to the usual care. As far as methodology of this trial was concerned, there were few differences in the methodology as compared to the methodology of last few previous trials. The most important difference was that the patients who were enrolled in this trial, they were enrolled very early in their disease process. So the median duration of AF after diagnosis was 36 days. So clearly, the most important message to be taken, I think, from this trial was that if you want to give the benefit of cardioversion, if you want to give the benefit of sinus rhythm, then it should be done early in the disease course. So the possible indications for conversion to sinus rhythm or the possible indications of cardioversions are a patient of atrial fibrillation who remains symptomatic despite adequate rate control. The second category of patients are patients of heart failure. I think in this category, the threshold of cardioversion should be low. Patients who remain symptomatic or who have severe symptoms of heart failure despite rate control, and patients of heart failure where we think tachycardiomyopathy as a cause of systolic dysfunction. All these patients are more likely to benefit from cardioversion. Other indications are AF with reversible cause, and maybe all patients who have new onset AF, they should also be given at least one chance of achieving sinus rhythm. So these are the drugs which are approved by European Society for Pharmacological Cardioversion. Flecainide and propafenone are Vaughan-Williams classification class 1C drugs, amiodarone and abutilide class 3, and there is a new, relatively new entry called Ventricle to class 3 drugs. So we'll discuss all these drugs one by one. Class 1A agents, the quinidine and procainamide, they are no longer preferred for cardioversion of AF. So we will not discuss too much about them. I was just mentioning them because they were the first one to be used for conversion of AF, but they gradually, because of their long list of side effects and modest efficacy, they are gradually off this treatment algorithm, and they are no longer used for conversion of atrial fibrillation. The preferred agents nowadays for conversion of AF for pharmacological conversion are class 1C agents. Basically, this is flecainide and propafenone. These two drugs, they have a better success rate and a favorable side effect profile compared to class 1A agents. In contrast to class 1A agent, these drugs, they do not prolong repolarization phase. As a result, the incidence or the risk of torsades is very rare with flecainide and propafenone. Nonetheless, they prolong depolarization, and therefore there are some reported cases of widening of QRS and conduction disturbance with these class 1C agents. In contrast, one of the disadvantages of class 1A agent was that when you use quinidine or procainamide, there was a risk of acceleration of ventricular rate. When the AF converts to atrial flutter, there was a risk of acceleration of ventricular rate. Therefore, while using class 1A, one has to concomitantly use beta blocker or calcium channel blocker. Whereas with flecainide and propafenone, the acceleration of ventricular response or one-to-one AV conduction is extremely rare. These drugs, flecainide and propafenone, they should not be used in patients who have class 2 to class 4 heart failure when the QRS duration is more than 120 milliseconds, in patients with sick sinus syndrome, acute coronary syndrome over last 6 months, and patients who have second degree or higher AV block. So basically, patients who have ischemic or structural heart disease or patients who have conduction system disease, class 1C agents are contraindicated. As far as the conversion rate of these drugs is concerned, the reported success rate with flecainide is as high as 90%, whereas propafenone is between 70 to 80%. And not just the conversion rate, even the speed of conversion is pretty fast. You can see it here that approximately majority of the patients, they convert to sinus rhythm within approximately 1.5 to 2 hours. So these drugs, they are pretty fast to act and they have a pretty high conversion success rate. In addition to class 1C, the next class for cardioversion is class 3 agents. Amiodarone, as we all know, is one of the most commonly used antiarrhythmic drugs. in medicine. It has not only it has class 3 antiarrhythmics. In addition, it has beta blocking, calcium channel blocker, and sodium channel blocker properties. The conversion rate with amiodarone, pharmacological conversion of AF, the conversion rates are less than flecainide and propafenone. In trials where the dose of amiodarone was more than 1500 milligram per day, which was considered high, the conversion rate was between 60 to 80%. Whereas when the dose used was less than 1500 milligram in 24 hours, the conversion rate with amiodarone was almost similar to that of placebo. So efficacy-wise, the amiodarone has a moderate efficacy compared to class 1C agents. So the list of side effects is with amiodarone is also quite long, especially on chronic use. But on acute use or short-term use, the risk of torsades is very rare. There are few reported cases with amiodarone causing torsades. Because of its beta blocker and calcium channel blockers properties, it may cause first-degree AV block, sinus bradycardia, and hypotension. But majority of these side effects, they are reversible and easily controllable by discontinuation of amiodarone. One of the biggest advantage of amiodarone is that it can safely be used in patients with structural heart disease and systolic dysfunction. This is in contrast to all other available antiarrhythmics. None of them can be safely used in patients with structural or ischemic heart disease, whereas amiodarone is relatively safe in this category. Ibutylide, another class 3 drug, it is approved for intravenous use for acute termination of AF and flutter. Ibutylide is given as a bolus of 1 milligram to be given over 10 minutes. And if the AF does not terminate to sinus rhythm, then the bolus of 1 milligram can be repeated after 10 minutes. And with this 2 bolus regime, the conversion rate at 90 minutes with ibutylide is almost equivalent to that of flecainide. Almost 50% of patients of atrial fibrillation, they convert within 90 minutes. The major risk with ibutylide is the risk of QT prolongation and the potential to cause torsade de pointes. Therefore, it is mandatory that all patients who receive ibutylide, they are monitored for at least 4 hours after the last injection, and the resuscitation equipment must be easily and immediately available. Ibutylide should be avoided in patients who have a baseline QT of more than 440 milliseconds or more, those who have marked hypokalemia, and if the ejection fraction is less than 30%. One more advantage, I think, of ibutylide is that it can be safely combined with class 1C drug, class 3 agents, and with electrical cardioversion. It increases the cardioversion potential of all these 3 modalities. In fact, we are also using for quite some time now. We have started using a combination of amiodarone and ibutylide together. We give oral amiodarone on outpatient basis for at least 3 weeks. And if the patient does not convert, then we admit the patient, give ibutylide, and after 2 boluses of ibutylide, we have found that the conversion rate increases to between 80 to 90%. Dofetilide, another class 3 antiarrhythmic, it is more or less an oral version of ibutylide. The reported success rate or conversion rate with dofetilide is to the tune of 30%, which is much higher than the placebo. But the major risk with dofetilide is again the risk of torsade de pointes. And majority of the patients who get this ventricular arrhythmia, they get, or this torsades happens within first.
Extremely sorry for the interruption, sir. 2 minutes of the screen time left. Thank you.
This arrhythmia occurs within first 3 days of therapy. So it is recommended that patients who receive dofetilide, they should be hospitalized at least in the first 3 days, which I think is the big disadvantage to difetilide. Despite being oral, it cannot be used on outpatient basis. So if we compare all these drugs, we find that flecainide has the highest success rate, followed by propafenone, and then closely by ibutilide. Then comes the amiodarone. Sotalol and quinidine are no longer used. The new entry to this class of drug is Vernaclant. It is indicated for new onset AF in patients who either have no structural heart disease or mild to moderate structural heart disease. The adverse event or the adverse effects with Vernaclant, they are more commonly seen in patients who have class 3, class 4 symptoms. The risk of hypotension, negative inotropic effect, and proarrhythmia, they are more common in these patients. Therefore, Vernaclant is contraindicated in patients of class 3, class 4 heart failure. The biggest advantage of Vernaclant is that it has a very high conversion rate, more than flecainide, and even the speed of conversion is very high. Majority of patients, they convert within 10 minutes as compared to 166 minutes with flecainide. But so there is one interesting concept in the pharmacological conversion of AFib, that is pill in pocket concept. Those patients who have very infrequent symptoms of paroxysmal AF, they are advised to take single dose of oral flecainide, either 300 milligram or propafenone up to 600 milligram. They can take these drugs at home to convert to sinus rhythm. But before they start taking this drug at home, it is recommended to demonstrate the safety of these drugs at least once in hospital setting. This is quite a very practical and also avoids recurrent hospital admissions of the patient. The American guidelines, they suggest that all these patients who take pill in the pocket, they should take beta blocker or calcium channel blocker at least 30 minutes before taking these drugs. So one most important thing in cardioversion, whether it is electrical or pharmacological, is that the risk of stroke and systemic embolism always remains there if the patient is non-anticoagulated. So all those patients who have AFib of 48 hours or more, they should receive anticoagulation of 3 weeks before cardioversion and at least 4 weeks after cardioversion. The long-term decision to take oral anticoagulation depends on their CHAD score. For those patients where we cannot wait for 3 weeks, then these patients should receive either injectable anticoagulation or NOACs, or transesophageal echo is recommended before cardioversion. So this is my last slide to summarize. If a patient has recent onset AF, or when we decide to convert AF, if the patient is hemodynamically stable, then depending on the patient's choice, we may opt for pharmacological cardioversion. In this, we have either the patient has, if the patient has severe ischemic or structural heart disease, then the only option which is available to us is amiodarone. If there is mild to moderate structural heart disease, then amiodarone again is the first choice, but Vernaclant can also be considered. If there is no structural heart disease, then the options available are flecainide, ibutilide, propafenone, or Vernaclant. For those patients who have very infrequent symptoms, pill in pocket concept, pill in pocket therapy with flecainide and propafenone may also be considered. Thank you.
Okay. Thank you, Dr. Vikas. It was a very informative talk. I would ask my co-moderator, Dr. Rajat or Dr. Pratap to ask few questions if it's required. I don't see any questions from the chat.
Okay. So, Dr. Kataria, it was a nice presentation, and there is a brief overview of how do we manage this acute atrial fibrillation? So a couple of questions here. Like if you see many of our patients who come to the ER with an atrial fibrillation, they're already on amiodarone, right? And they have an extremely slow heart rate. So we still don't know whether the patient has an underlying sick sinus or not. So how do you feel the cardioversion, the role of cardioversion? And then number two, when it comes to use of many of these antiarrhythmic medications, except the class 3, there is an hitch about structural heart disease. So many people, they are really afraid of giving class 1 antiarrhythmic medications to even revascularize. So what is your take on this kind of scenario of atrial fibrillation?
Yeah, I could not hear the second question because of some, I think, network issue.
Okay. So
yeah.
Many of our patients who come to the emergency room, they're already on antiarrhythmic medication and mostly to the amiodarone, and they have a very, very controlled ventricular rate. Still, we try to cardiovert to sinus rhythm. So we have no idea whether this patient has structural heart disease. So will you be very comfortable cardioverting these patients who are on amiodarone? There's a slow ventricular rate. And if you want to take some kind of precaution in such kind of scenario, what will be that? And the first question, as you know, I told. And the third question is structural heart disease. So how we should try to strategize our identify our patients like who are minimally having abnormal structural heart disease versus a grossly structurally abnormal heart, so far as the antiarrhythmic medications are concerned.
Right. I think,
and the fourth question will be as you told, like amiodarone, pre-treatment with amiodarone and the cardioversion giving rise to more conversion rate following in cardioversion. So what will be the flecainide?
I think there's some issue with Dr. Rajat. Basically what he's trying to say is if there is a tachybrady syndrome with AFib and the patient has a well-controlled ventricular rate, do you still go for a chemical cardioversion? Or if you're going for a chemical cardioversion, what precautions do you take? We'll take questions one by one. That will be better.
I think that is better. I think if the patient has already very slow rate on amiodarone and is very well asymptomatic, then we have there is no compelling indication as far as scientific evidence is concerned to cardiovert. The patient can, if asymptomatic on rate control, then there is no urgency of controlling that rate, controlling the rhythm. And since the patient is already on amiodarone, I think the has not converted, it itself means that the chances of cardioversion are already low. But if that patient is symptomatic and if the decision of cardioversion is taken, then I would be more comfortable with since the amiodarone has not worked, then we can use the other agents, but with the cover of, I think, pacemaker.
Yeah, that's the way to go. A quick question to you, Dr. Vikas. Practically, which subset of patients would you prefer a chemical cardioversion? Okay, forefront chemical cardioversion rather than going for a DC cardioversion. Practically,
yeah. Practically, I think as we discussed earlier, the majority of the patients who remain symptomatic despite rate control, or when we find that achieving a good rate control is not feasible or is not being possible, then those are the patients where we try chemical cardioversion. Those who remain symptomatic, either rate control is not possible or despite rate control, they remain symptomatic. And the second category is
who gets upfront
heart failure patients who, for example, tachycardiomyopathy. Sometimes it is extremely difficult to find out whether the LV dysfunction is because of AF rate or not. So I think all those patients of heart failure should at least get one chance of cardioversion.
Yeah, fine. Which patient gets the upfront strategy of pharmacological cardioversion against a DC cardioversion? That is what I was trying to ask you. Basically, patients who do not have structural heart disease, patients who do not have who have a bad airway disease, who might require a general anesthesia backup, or something like a patients who have AFib less than of shorter duration. These are the patients whom we will prefer for a pharmacological cardioversion at the first attempt. So
those patients who do not have a pacemaker, where pacemaker malfunction and other things. Yeah, definitely. These are the patients who where pharmacological should be the
first option. Yeah. So how much of failure do you get from this pharmacological cardioversion, where they would secondarily try to get a DC cardioversion after that?
Overall, in general, if you take all the antiarrhythmics together, then approximately 50% of patients they convert with chemical cardioversion.
Yeah. And when it comes to India, which drugs do you prefer? Which will be your first drug? If it's a structural heart disease, you have told me that it is an amiodarone. Okay. If it's a non-structural heart disease or a lone AFib, which is the first drug you will want?
If there is no structural heart disease, then oral flecainide or intravenous ibutylide.
Yeah, fine. So there are lots of apprehensions about use of flecainide after the CAS trial. So which do you still try to use in patients with mild to moderate structural heart disease, flecainide?
No, I would be highly I would not be very comfortable while using flecainide in patients who have ischemic or structural heart disease.
Okay. And any pre-treatment with magnesium or something is required before you use ibutylide?
Yeah, some experts have used magnesium before giving ibutylide to prevent the risk of proarrhythmia. But again, as we discussed, we have used ibutylide in, I think, more than between 100 to 150 patients without using magnesium, and we didn't find any such risk. So I think without magnesium is also equally acceptable.
Okay, fine. And have you ever faced anything like increase in defibrillation threshold after use of amiodarone or ibutylide?
No, in fact,
ibutylide
in fact has been found to increase the success of electrical conversion.
Fine. And important point which you drive home is about role of anticoagulation. So it is similar to electrical cardioversion. Okay, anticoagulation is a must for all these patients, depending on their CHA2DS2-VASc score. Is that 48 hours time which is set in the guideline? Do you really strictly follow that, or practically do you want to still do a TE if the patient comes in 24 hours also?
Yeah, I would like to do a TE practically in all patients, but sometimes it's not possible. And the reason behind this is because the history, or it is very difficult to ascertain the time window, whether it is really 24 hours or more than that. It's sometimes difficult to ascertain. So we give anticoagulation in all patients, even if the AF is less than 40 hours of duration, and in majority of the patient we try to do transesophageal echocardiography.
Yeah, fine. So there's one question from the chat, which is asked by Prabhakar Dorerajan, doctor. He says that in his trial, overall adverse effect with event with rhythm control is around 5% when compared with standard rate control. So the safety outcome could have been equated by the stroke and the mortality, which also contributes to this efficacy outcomes. Can you comment on this? That's what he's asking.
Can you just repeat this question?
Yeah. So in his trial, the rhythm control fared worse than standard rate control. So the safety outcome was equated by the stroke and the mortality. So can you comment on this? That's what he's saying. So if he's asking whether do you really still prefer to do a rhythm control since the adverse event has been bad with the rhythm control.
Yeah, I think.
Let's talk about the acute conversion. I think this could be discussed later. But there are two things which I would like to highlight here. One of the brightest minds of electrophysiology from the country who has escaped to Canada, and we got to get that mind back to India, is Sharad Kumar. I don't know whether you are seeing his question. It is so very apt with respect to the acute conversion of atrial fibrillation. He has two fundamental questions. And this guy is known for this basic the inquiry about the basic issues. Sharad Kumar, thank you for putting up that question on your behalf. I am asking. These are very relevant questions. Joseph, I hope you permit me to ask that.
Yeah, please.
Yeah. He says, I believe all should be electrically cardioverted if you really think there is a necessity. Number one, you don't go by the drugs. He says, if you think it is required, just go and cardiovert. And then he says, anti-arrhythmic drugs should be used only when it is resistant to electrical cardioversion. I think it is absolutely a great thinking. When you require, you go for cardioversion, take precautions. But he says, pharmacotherapy at this point in time is inferior to cardioversion. So because
definitely, if the cardioversion or achieving sinus rhythm is a necessity, then I think electrical cardioversion is the answer. But again, as in our algorithm, I showed that it's ultimately the patient's choice. If patient is ready for electrical cardioversion, then definitely the success rate is much higher than pharmacological conversion.
All right. A patient is not giving you a choice. I think you made a point.
Yeah, of course.
By the way, again, Joseph, can I ask you permission? Amit Vora, is the biggest of the minds. He had been, the pioneer in this atrial fibrillation, rheumatic heart disease, etc. Amit Vora, I think I'm seeing on the screen here. I hope he unmutes himself and he just throws some light. Just about a minute. If Amit Vora is around, I would love to hear from him. Rheumatic heart disease continues to be a huge problem. He has got such a work towards atrial fibrillation, rheumatic heart disease. He talks about cardioversion, pharmacoversion, etc. Sarji, Amitji, if you are listening to us, 1 minute comment from you, please.
Thank you, Ulas. So I think rheumatic atrial fibrillation continues to be a significant burden and a challenge in our country. And I think recently publication from Aditya Kapoor, SGPGA Lucknow, I think all of us should get into it, because though it is a pilot study in rheumatic atrial fibrillation, they have used flecainide and electric cardioversion, and they found flecainide to be safe enough. It's a small study of some 50 patients, but it is a worthwhile option, because earlier from the CRAFT study which we had done, we were using amiodarone and electric cardioversion, and we all know the problems with amiodarone in young people, how long to continue, the potential side effects with amiodarone. So we do have a challenge with amiodarone and rheumatic atrial fibrillation in terms of the side effect profile of amiodarone. So flecainide is a good study which has come up, but obviously this is just a pilot and it needs to be properly evaluated in a prospective randomized trial. In short, I would think that rheumatic atrial fibrillation rhythm control is important. Most of the studies, rate versus rhythm, it says the rhythm is no superior. But if we categorize the etiology, rheumatic valvular heart disease, having sinus rhythm, definitely there's a good chance of a better quality of life. And the prothrombotic state in patients with rheumatic valvular heart disease and valve replacements, which the AFib adds, is another challenge in terms of thromboembolism. So I would think rhythm control for rheumatic AF stands a role, and flecainide needs to be evaluated.
So, Dr. Amit, thank you very much. And, of course, Aditya Kapoor's work is always appreciated. Very quickly, one last comment. Ibutalide, we have found could be very good, not necessarily only with structurally normal heart. Cardiomyopathies, ischemic cardiomyopathies, even with rheumatic heart disease. Maybe very quickly, I would like to tell people, ibuprofen is one of the greatest of the drugs for the acute pharmacological conversions of atrial fibrillation, and maybe it's a time for us to, create a registry. Thank you, Vikas, as usual. Wonderful. Joseph, we miss you from Madras. And thank you very much, Rajat. Thank you very, very much. So it's time to go to Dr. Kapil Kumawat, one of the most accomplished electrophysiologists, and then work is so very well appreciated. He's from Naranurdalaya, Bangalore. His talk is going to be coming up now, and we have the professor of cardiology and electrophysiology from All India Institute of Medical Sciences, the prestigious institute of the country. Nitish Naik is going to take over the session and to be ably assisted by my dear friend Aparna, another accomplished electrophysiologist. Hi Aparna, and Natarajan. Natarajan, we always crave for his inputs, and thankfully again, he has come today. Welcome Natarajan, Aparna, and Nitish, take over please.
Thank you, Ullas. Thank you for inviting us, and it's such a pleasure to be here, and we're really enjoying this academic feast that you have organized for us. And I have great pleasure in inviting Kapil. Kapil is a very valued friend and colleague. Unfortunately, he has moved down south. We wish he had stayed back with us, but now he is at Narayana in Bangalore and doing good work. And before that, I think so, he was at Monash in Melbourne, and he's done some fantastic work in electrophysiology there. And we are very lucky that, he's over here. And Kapil is going to walk us through a different case of syncope that has been unraveled by, long-term monitoring. It's one of the most difficult cases to handle. And I'm glad Kapil is going to teach us how we can go about this. So all over to you, Kapil.
Thank you, sir. First of all, thank you, Dr. Ullas, for inviting me for this wonderful session. And all the sessions have been really, really great. On Teachers' Day, I would begin by expressing my gratitude to Dr. Nitish Naik and other teachers, because of whom I've been considered worth to give this talk. Now, the talk handed over to me is a case of syncope unraveled by rhythm monitoring. So usually when a case is presented, we think of some exotic thing, and especially with rhythm monitoring, we do encounter certain very unique cases like short coupled torsades or idiopathic VF being initiated by a VPC or something of that sort. Unfortunately, my case is nothing like that. It's a pretty simple, straightforward case. But what I would like to highlight is how to actually incorporate long-term rhythm monitoring into our practice, especially given the cost constraint and the general sort of awareness about using these rhythm monitoring devices, and hopefully initiate some discussion later on. So straight to the case. The case is of a 61-year-old female, hypothyroidism, euthyroid on medication, a chronic kidney disease, on maintenance hemodialysis 3 times per week. Now, according to the nephrologist, it was a renal limited amyloidosis. They had extensively evaluated the patient for systemic amyloidosis, but they found no other organ to be involved. There was no hypertension in spite of being stage 4 kidney disease. There was no hypertension, surprisingly. Probably amyloid had to do something with that. No diabetes. Now, had undergone coronary angiography 4 years ago with no significant coronary artery disease, and the LV functions were normal. Now, she has had 3 episodes of loss of consciousness in last 4 months before presentation. I'm not using the word transient because we don't know some of those circumstances. Now, the first episode was thought to be vasovagal, happened after she tried to get up from the bed after the session of dialysis, and it recovered in few seconds. It was transient, observed, and it was very much like a vasovagal. And so nothing else was done at that time. More fluids were advised by nephrologists for a couple of days, and that was it. Second episode happened 2 weeks after the first episode, just before a scheduled dialysis. Now, the circumstances of this episode was not very clear because the patient was at home alone. She became unconscious while cooking in a standing posture and regained consciousness maybe after a few seconds. She's not very sure. Now, serum potassium was found to be elevated when she went for her dialysis, the scheduled dialysis. It was 6.5, underwent routine dialysis without any complication. Potassium was taken out and was corrected. Now, when she presented to the dialysis center, the pulse rate and blood pressure were found to be normal, and throughout the dialysis and after that, they were normal. Now, ECG was done after the dialysis, which was deemed normal. And at that time, she was referred to a cardiologist. This is the presenting ECG. I hope it's clear, but it was unremarkable except for the fact that it is maybe a little low voltage, but otherwise pretty normal. Now, the echo was done by the cardiologist and they didn't report anything abnormal in the echo. They did a Holter for 24 hours. It was essentially normal. No symptoms are reported during that Holter, so we don't know whether it had helped at all or not. Now, the third episode happened about 6 weeks after the second episode, and this episode happened actually during dialysis when the patient was supine. The daughter observed that the patient was unresponsive and called for the nurses. And by the time the nurses came, the patient had regained consciousness. And the heart rate recorded by the nurse at that time was 60 per minute. The blood pressure was slightly on the lower side, but was nothing to be alarmed about. The ECG again was unremarkable. Now, I just wanted to highlight the fact that in India, when dialysis is happening, in most of the centers, which are busy centers, they don't attach a cardiac monitor to the patient. And many a times the dialysis, especially for the routine customers, is done without any monitoring. And unfortunately, in this case also, there was no monitor attached to the patient to find out what had happened. Now, the patient was referred to neurologist, which is the usual scenario in most of our syncope patients. And a full set of neurological workup was done, including brain MRI, a video EEG, and carotid Doppler, which were all normal. And at this stage, she was referred to us. Now, we had to consider various options to further evaluate this patient. Tilt table testing was to be considered, but the last episode was actually in a supine position where postural reflex mediated vasovagal was very, very unlikely. A long-term ECG recording, which is what we actually considered, given the scenario. Further neurological workup would have been warranted if there was a systemic amyloid, and especially autonomic dysfunction would have to be considered. And electrophysiology study. Now, in fact, the nephrologist referred this case to us for electrophysiology study rather than for anything else. Now, we had to respectfully decline EP study because most of the times in suspected bradyarrhythmic episodes, EP study does not add to any clinical sense, and it is mostly of no use. So we decided to do a long-term ECG recording. We did a long-term Holter and not long-term ELR. This is a in-house developed Holter system designed in collaboration with a startup cardio design lab. It uses a AAA battery, single AAA battery in the recording system, which is attached to the 4 leads. And this can actually be communicated to a handheld mobile given to the patient, which can continuously transmit data to the call center, especially the alerts. Now, the alerts are built in the system as well as in the mobile. So only selected alerts can be transmitted, and it can be transmitted even on a 2G network. It doesn't require a high speed network to transmit the data. And this is very, very cost effective. We use this kind of extended Holter, especially for our stroke of unknown origin cases. And it has been found to be really useful and very cost effective. Now, it was normal. So the 4-week Holter was normal. So we did even long-term rhythm monitoring. We implanted a Reveal XT loop recorder in the left precordium. And 1 month later, the patient presented with recurrent syncope, especially clustered over a 2-day period. One of the episodes was pretty long. You can see it was recorded as asystole for 33 seconds. And this actually was found to be correct on inspecting the the raw data from the device. So here, with some broadening of the QRS, the syncope begins, and there is a asystole, almost maybe there is a escape or there is a rhythm here, a contraction here, but for 2 pages almost there was no rhythm at all. This is the 33-second pause. Now, fortunately, the patient recovered without any neurological deficits, and this actually baffled us. Now, if you look carefully, it is not a asystole because of sinus arrest, but there are P waves which were visible, and so it was a third-degree AV block, which actually led to asystole of this kind. Now, this could, these VPCs, so these broad QRS complexes here may point to a phase 4 block kind of thing, but there were 2 other episodes which just started just like that without any prodrome or without any warning. Now, the patient received a dual chamber permanent pacemaker and has been doing well for last 1 year. We didn't try to actually go into the details as to why this patient had this kind of complete heart block, but cardiac limited amyloid along with the renal amyloid might have been responsible for this thing. The treatment would not have changed even if we identified a cardiac amyloid in this case. Now, cardiac monitoring system, we all know, can be Holter monitors, event monitors, or post-event recorders, or mobile cardiac output telemetry, a fancy name given for current event recorders, or loop recorders, or wearables and other retail gadgets, which I'll briefly touch upon. Now, Holter monitor can record up to 24 to 48 hours, but like in our case, we can now record it up to 4 weeks. There can be 3-channel or 12-channel. The biggest advantage of Holter is that it provides a raw data, which is not dependent on any algorithm, and you can analyze that data and find out even the minutest of the problem if you spend some time with the Holter data. And the biggest limitation, of course, is the brief duration of monitoring and the physical size of the device, which makes it cumbersome for the patient to carry. Though miniaturization in Holter is also taking place, like what we are trying to develop in our in-house system. Now, post-event recorders never gained popularity in India, but basically these are the recorders given to the patient, which the patient has to activate after the event has taken place. So most of the times they are not actually useful in cases of syncope, but may be useful in cases of palpitations to identify tachyarrhythmias. Now, loop recorders can be implantable or external. Now, basically, loop recorder does not record all the ECG. It loops, the memory is looped, so the previously recorded ECGs are continuously wiped off until unless there is an area of interest which needs to be stored in the memory. Now, external loop recorder are pretty common these days, and they are gaining popularity because of various reasons, especially because of the miniaturization. Now, we have external loop recorders for up to 30 days. They are useful if the episodes are occurring within a 2 to 4 week period. Usually they offer only 2 leads for the recording. So a single channel is recorded most of the times. They are now available in patch form also, and a very fancy MCOT, which is the name of a patch recorder, external loop recorder, which can communicate with the mobile of the patient and can continuously transmit data and alerts, is available by many startups in India as well. Now, implantable loop recorders, which are gaining popularity in India also slowly, but the extent to which the attention they deserve, they have never got it, especially because of the cost considerations. Now, they can record ECGs up to 4 years, and they are also loop recorders, so they don't continuously record all the ECGs. It's very simple implantation, usually in the left parasternal area, can be done on an outpatient basis, does not require a patient to be taken to a cath lab, can be done in a CCU or even in OPD base or even in the patient's room. And these are what are usually available to us, Medtronic Reveal and Reveal XT. Medtronic has also launched the Reveal Link, which is pretty small and is compatible with the home monitoring. St. Jude had Confirm initially, which was never made available to us, but now Confirm RX is available to us, which actually has a Bluetooth technology, pretty small, communicates with the patient mobile and can continuously transmit data. Biotronic says they can make this BioMonitor 2 available to us as well. Now, ILR acts on 2 modes. Patient activation, that is after the event, patient can activate the device by a handheld gadget given to the patient, and then it marks an area of interest, and the ECG before that event and after that event can be saved in the memory of the ILR. There is also auto activation. Whenever the device detects any bradycardia, asystole, or tachycardia, it automatically stores the relevant sections of ECG in its memory. Now, this is one of the examples of the patient activator. The patient has to put it on the over the ILR and press the button so as to give message to the ILR that the area of interest is to be saved in the memory. Now, this is just about the confirm RX. It is very thin, 3.1 mm. It is around 5 centimeters long, and it comes with an insertion tool. So you insert the insertion tool after giving local anesthesia into the subcutaneous tissue and inject the device, which is kept inside this insertion tool, just like a plunger. Then you just program it using the usual programmer, and then you pair this device with the patient's mobile through Bluetooth, and then it can be available on the Merlin net of Abbott and can continuously transmit data or transmit the data whenever the patient wants it to, or at a particular time which has been pre-programmed. Now, this is the comparison of all the modern gadgets available by the 3 major companies, that is the Confirm RX, Reveal Link, and Biomonitor 2. Now, Reveal Link and Biomonitor, they work on the patient's bedside transmitter using RF technology. They are not yet compatible with the Bluetooth technology. Medtronic is about to launch one of their products very soon. St. Jude Abbott has the maximum recording capacity of around 57 minutes.
Sir, I'm extremely sorry for the interruption,
yes,
sir.
Yes, I'll be finishing.
2 minutes of the screen time. Thank you.
Sure. So the biggest limitation of ILR is basically that it has a limited capacity to record, and if there are signal noises, the capacity gets filled very quickly. And most of the time, it is the alerts which are recorded, so you can't actually see the raw data, and cost is a major challenge, especially when you compare it with a single channel pacemaker available to us. So many a times, instead of putting a diagnostic device, clinician thinks of putting in a diagnostic as well as a therapeutic device in form of a single chamber pacemaker. Now, ILR has been awarded a class 1 indication in various scenarios, especially in cases where recurrent episodes are there and initial high-risk monitoring in hospital does not reveal anything. It is also recommended for cases who are being treated as epilepsy, unconfirmed, and have not responded to therapy. It is also recommended for unexplained falls in elderly patient, and the yield is around 18 to 20% in such cases as well. This is the same thing in a tabulated form, this ESC 2018 guidelines. Now, compared to conventional strategy, including EP study in cases of suspected bradyarrhythmia, the yield of implantable loop recorder is 3.6 times. And this is what should actually push us for using more ILRs. This is the last slide. Now, things are going to change with these wearables and retail products being available, from as simple as a pulse oximeter or the health band, which can record the patient's heart rate. Now, unfortunately, they cannot tell us about the rhythm, but heart rate can be recorded in using these gadgets very quickly. Now, many of the pulse oximeters, they also give a waveform to actually know whether the recorded heart rate is correct or not. Now, this is a very useful, AliveCore, we all know. It's internationally available FDA approved device, which can be paired with a smartphone to record a single channel ECG. But similar device called Sanket ECG is available. It is almost 1/4 the cost of AliveCore and does the same job. In fact, using Sanket ECG, you can record a 12 lead ECG as well. Now, these are the ones, the wearables which have recording facility for ECG using a smartphone, Apple Watch 4 and 5, which all know. But similar thing by Indian company GoKey ECG, 1/10 the cost of Apple Watch is available. I've been using it extensively and results are very good. Now, unfortunately, all these are pretty useful in assessment of palpitations and tachyarrhythmias and not so much for syncope. Thank you very much.
Thank you, Dr. Kapil, for that excellent case of syncope. As Dr. Nitish introduced the case right in the beginning, it can be a very vexing problem. Syncope, sometimes it can be very easy. You have a syncope, the ECG shows a complete AV block, the matter is over, you put a pacemaker and you've been done with it. But we do come across cases of syncope with all the evaluations under the sun, except the ILR that you said. You are back to square one. Everything. You don't know whether you are dealing with tachyarrhythmia, bradyarrhythmia. And I agree with you that the ILR is a very underutilized tool. And when done in selected cases, you should not be very loose in your indication. When the diagnosis is obvious, you should resist the temptation of putting an ILR. In the cases of the nature that you presented just now, where after everything it is very, very confusing and you don't know the diagnosis, definitely an INR goes a long way. And we have also had a few cases where it unraveled the cause of syncope. And maybe Aparna wants to add something.
I think that was a very nice case, Dr. Kapil. Congratulations. And as Dr. Natarajan said, sure, it is underused. And I think even in cases like cryptogenic stroke, where we really want to today look out for atrial fibrillation, that is one place where I think it is truly underused, because we do a day's Holter, and with the safety of NOACs available to protect our patients, I think that's another place where the utility of ILR, especially with the Bluetooth, I think I am so happy with the Confirm RX, which is now available. So I think that is a very good case.
I didn't actually highlight one thing. Sometimes it is more useful to rule out a diagnosis rather than rule in a particular diagnosis, especially in cases with recurrent syncope, where pseudo-syncope because of psychogenic causes is a big thing. You can actually have these implantable loop recorder telling you that the rhythm was absolutely normal when the patient had these episodes, and then you can effectively rule out a serious cause of syncope, cardiac cause of syncope in these patients.
Yeah, that's a very good point. And in fact, about 10 days ago, I had this young lady in her early 40s, and they were well-to-do, and had been advised a pacemaker, and somehow it didn't appear that she needed a pacemaker. Now the husband wanted that, let's go ahead and put a pacemaker. If you want to put an ILR, if you have to do something. So, it took a little bit of telling them that, you don't want to go endovascular. In fact, he said, go ahead and put a leadless pacemaker. So I was like, you're really going over the board. Let's just put an ILR. And true enough, we put an ILR. She's had symptoms and there's nothing at all. So I completely agree with you. It does help you rule out and save your vessels.
So Nataraj and Nitish, if you permit me, we have Raj, a dear friend and an accomplished interventional cardiologist from Chennai. He deals with some arrhythmias and syncope, etc. I think we should welcome Prabhakar. Prabhakar, welcome. And your comments, please, Prabhakar.
Well, I don't do much of electrophysiology, but I think the case he presented was beautiful. I think as a general interventional cardiologist, our utilization of the ELRs and ILRs is much less. After looking at this case, I think we should be probing more into these, seriously. And Natarajan is my classmate, if you didn't know Ulas.
Yeah. And Kapil, I just wanted to add on to what Dr. Aparna was just mentioned. You also, during the course of your talk, did mention that most of the time ILR picks up bradyarrhythmia, especially in structurally normal hearts in young patients, where the chances of having a tachyarrhythmia is very, very less. And you now have pacemakers which will also record high rate episodes. And the cost difference between, if you say reveal link, if you say the single chamber pacemaker is only marginally more expensive. She did mention about saving the vein. Single chamber pacemaker in a grown up patient with adequate body weight does not actually compromise on the vein. And it also prevents the syncope if it is a bradyarrhythmia. Your patient, if the patient had a pacemaker, the device would have recorded the episode of high grade AV block. It should have told you the percentage of ventricular pacing. And so what's your comment about that? When the risk of tachy is less, brady is high.
Yeah, so we do use this strategy if there is even a slightest hint that this could be a bradyarrhythmic event. For example, if there is a bundle branch block, for example, or maybe a prolonged PR. In such scenario, we give choice to the patient whether you want a more diagnostic workup, which will be equally expensive, or you just want a therapeutic modality which may not be accurate. You may still get another episode of syncope, which if the diagnosis, suspected diagnosis is not correct. But in this particular case, we did not have any sort of reason to put in a pacemaker. And we should not be forgetting that actually the pacemakers over a period of 10 years have a complication rate close to 15%, be it infections, be it lead failures or revisions, whatever. So putting in a pacemaker should not be taken so lightly, not just from the point of view of sacrificing a vein, but they have their own sets of complications. And if you put a single chamber pacemaker in a patient like this, a complete heart block patient, then the patient would be losing out in terms of the quality of life, or maybe develop episodes of diastolic dysfunction related congestive heart failure episode. So I believe that in certain scenarios, especially if you're not very sure, putting in a more effort to diagnose the condition correctly should be the criteria. And as we start using these loop recorders and other stuff, I think the cost will come down, especially, for example, for Medtronic Reveal XT, which is available at a price which was half the price of what it was 5 years ago. So I think the prices will come down if we keep on using them more and more. That's my take on it. So I would not put a pacemaker just on a hunch until unless there is a slight clue either in the ECG or in the presentation somewhere.
With you on that. My comment was, Kapil, like you rightly showed, that paroxysmal AV block is impossible to diagnose, very difficult to pick up on, because your ECG is going to be normal, and it's only your clinical suspicion that drives you in that direction. When you feel, like you rightly said, your loss of consciousness, you didn't know what was it transient or longer, and it's longer, that's when you suspect AV block. But what is your, experience on using adenosine in these patients? Because there have been some reports of people using adenosine to uncover paroxysmal AV block. I know most of us have seen just a handful of, not even a handful of patients in our own careers.
Sir, with cardio-neuro ablation, picking up, I think we will be more tuned to looking at these patients, especially if a young patient with a narrow QRS escape rhythm with a 2:1 AV block or even a complete heart block. I think in such scenarios, we'll be more tuned to looking at adenosine sensitive AV blocks and maybe approach these patients with cardio-neuro ablation in times to come. But as of now, my experience is very limited in this.
Dr. Shiv Kumar is there, so maybe we can ask him.
Yes.
Nitish, I think, when it comes to autonomic nervous system modulation and all that, I think we are going in a little different way. But how nice, Nitish, you coordinated very well. Natarajan, Prabhakar, Aparna. Thank you very much. Great job. So, ladies and gentlemen, with this, we are coming to the last session of this Cardiac Rhythm Council 2020 meeting. Even though it is the last of the session, but let me assure you, this particular session, which is the last session, is going to be actually the beginning of the renewed interest in the faith of electrophysiology, in the faith of ablation, in the faith of autonomic nervous system. It's because this particular session is going to be taken over by one of the finest teachers of electrophysiologists, not only from India, from across the world. On the Teachers' Day, it's a tribute from Madras Medical Mission, Cardiological Society of India to Kalyanam Shivakumar, had been wonderful teacher to the electrophysiology community. He had collaborated so many works in electrophysiology. He made Indian electrophysiologists to work along with him. There are several publications he made the Indian community to be involved in it. And we have been so very grateful to you all these years. You have been, Kalyanam Shivakumar, you have been always supportive of the electrophysiology program. So even though for some reasons we tried to accommodate, but we could not put you in the first lot because of your busy schedule. However, it's icing on the cake. Your talk is the final session of the Cardiac Rhythm Council, and we are honored to have you on the screen. And you are going to be accompanied by one of the finest brains of electrophysiology in the country. Both of them have been the past presidents of Indian Heart Rhythm Society, Dr. Mohan Nair, your close friend who admires you, accompanied by Amit Vora. All of us admire your work, your passion for teaching. And for some reason, your session got at the end, but then it's a blessing, I thought, because your talk at the end is going to continue our interest in electrophysiology, in ablation, and everything that is associated with arrhythmia and heart failure therapy. So again, from the behalf of the Cardiological Society of India, national body, Cardiology Society of India, Chennai chapter, I warmly welcome you, and I ask Dr. Mohan Nair to take over, introduce him, and conduct the further proceedings. Mohan Nair.
Thank you, Ullas. Good evening, Shiv. Good evening, Amit. Good evening, all the other participants. In the morning today, someone called me from Ullas' office and said, you're going to introduce Shivkumar Kalyanam. And have you gone through his CV? I said, yeah, perhaps I have. I know him. I've gone through the CV. So he said, please go through that and introduce him. I said, if I do that, then we will have a talk tomorrow morning. So as Ullas has already very rightly said, briefly, of course, Shivkumar Kalyanam, for official reasons, is the director of EP at the University of California at Los Angeles. He's also the editor-in-chief of the Journal of American College of Cardiology, EP. But far more than that, he's been one of the greatest friends of India and Indian EP. And we can't have a better introduction than that for Shivkumar Kalyanam. And he's talking of something which is actually very contemporary, but knowing Shivkumar, he will tell us something that is even more futuristic too. The topic is idiopathic VF. Maybe a few years back, we would have thought that that's an oxymoron to have idiopathic ventricular fibrillation. But now increasingly we understand the importance of that. And I don't think Ullas could have selected a better speaker than Shivkumar Kalyanam. So over to you, Shiv.
Mohan, thank you so much for the kind introduction. And Ullas, thank you so much for the kind words. This is a great honor and a privilege for me to, of course, present to my own home people, and of course I'm from Chennai, and in fact I grew up not far from where Ullas practices. So it is such a pleasure and an honor for me to have this rare opportunity to talk to all of you. So I was actually debating a little bit about how to present to to the audience, because every time I talk to the group in India, I come away from that meeting with completely renewed knowledge, because it's no surprise to say that most of what I learned, and I'm going to be sharing my slide in a second, I end up learning so much from every visit in India. And again, I can't thank all of you enough, because starting with Mohan's paper in Circulation on mechanisms of AFib and mitral stenosis, Amit Vora's work on rheumatic heart disease, AFib and mechanisms of arrhythmias, Yash Lokhandwala, Narasimhan, Ullas's work has taught me more about reading ECGs. So it's a rare honor again, and I can't thank all of you enough. Thank you for accommodating me here, because we had a 2-day big National Institutes of Health symposium that prevented me from giving this talk at the earliest slot that Ullas gave me. Now, all of you are able to see my slides?
Yes.
Perfect, thank you. So I'll start off with the first part of my slide, and this is the first slide that I put up in all the talks I give anywhere in the world. And this is, basically, this is the mission statement of our group at UCLA. And if you look at this particular slide, the left upper corner actually shows you complex anatomy and interventions, and the other side actually shows you a confocal image of nerves in the heart. It sort of bookends the science we do, which is patience to basic science. And if you look through this particular slide, there's also another little observation over here, and that is all our funding sources. So one of the most important funding sources that we got to do research, and I'm forever grateful for it, actually comes from the Indian Council of Medical Research. ICMR, when I was a medical student at Kilpauk Medical College, gave us a 500 rupee grant. So it was actually that 500 rupees paid for enough ECG in using an old BPL cardio art, which some of the older electrophysiologists may even know, a single channel ECG recorder with which I was able to get ECGs in children. It really got me interested in research because my physiology professor, Dr. Gajalakshmi at Kilpauk Medical College, got me interested in science. And of course, the only reason I'm sitting in Los Angeles now and giving this talk instead of being by your side is because of science. So anyway, it's also been a great experience now having an entire group of people you see over here. We have 21 faculty members in electrophysiology at UCLA, of which 4 are PhD researchers, and there are 3 electrophysiologists who do clinical care and science. So anyway, all the work you see over here comes from the team, and it's a privilege for me to present this data to you. So addressing the topic that was handed to me today, it's sudden death. So it's kind of interesting to see world literature. And of course, in India, we grew up reading so much about legends and history. It's always fun to actually read other cultures and what they describe in their literature. And this is a slide that was given to me, one of my first mentors at in the US. It's Dr. Sidney Goldstein, a wonderful man. His contribution was to use beta blockers post myocardial infarction, the beta blocker heart attack trial. So Sidney Goldstein actually showed this famous painting to me, and this is actually a count who comes back after a hunting expedition, and his servants run up to him and they give him a bowl of cold water to wash his hands. And of course, the moment he puts his hands into the water, he falls back and he says, his face turns white, his heart throbbed violently, his legs failed him, and he died. So, and he says, I'm dying, Lord, God have mercy, is what he last says. So, but that is an example of sudden death. And of course, this could have been ischemic VF or it could have been idiopathic VF, we do not know. But it is not uncommon. So when you look at sudden death itself as a challenge, it's massive. 22 people die every minute in this world of sudden cardiac death. And of course, we know the paradox that there are more people as a percentage of people with low EFs who die suddenly. But if you look at the overall number of deaths, there are more people who die suddenly who have normal or EF or very minor heart disease. So this is the whole paradox, right? Circle upon circle upon circle tells you about normal people, people with mild heart disease and people with severe heart disease. But this oval shaded number is the actual number of people dying suddenly. So this number that epidemiologists teach us is stunning. 22 deaths per minute in the world. I mean, this is a drop in the bucket compared to the number of people who are dying of COVID. So, and again, sadly this year, COVID deaths are being added to this. So we think that these episodes are because of VF. And here's a classic example of a PVC causing VF. And what drives this arrhythmia? We'll talk a little bit about mechanisms, and certainly we'll talk about what we can do here and now, which is how to intervene for that. So having this sort of a big picture finding in place, anytime you see idiopathic VF, it is dramatic. Of course, it presents as, in some cases as VF storm. Some cases is very sad. It's, they're arrested, they're dead. Other cases, they arrest, they get revived, and then they have PVCs or something that tells you that there is an electrical abnormality. So how do you deal with this? It's not an easy group of patients to work up. They are rare, but then if you don't look for it, and if you don't have your referring cardiologists and others to be a little bit tuned to this, you may never be able to pick it up. So So let's talk a little bit about the diagnosis. So the diagnosis of this condition, of course, requires very thorough workup. A big role here for cardiac imaging. MRI has been very useful because it's a reliable way to exclude scar. Not easy to do, and it's not a question of Asia or Europe or America. It's within America. I can tell you there are so many hospitals that simply cannot even do this protocol properly. So that is a bit of a problem in terms of MRI, but you need to have reliable MRI. And of course, many of you are extremely experienced, so you have a good intuition of the kind of patients you're going to be monitoring for. A second test that has had a big impact in our practice, and this is something we learned from the work by Narasimhan, is to actually use PET scans. And of course, this has completely opened up the world, not just for sarcoidosis, but any inflammatory cardiomyopathy. So subtle inflammation is perhaps the biggest item to exclude when you're working up patients with idiopathic VF. And I believe that some of the cases of idiopathic VF that you see in the literature have been misclassified. They probably had focal inflammation. I actually sent a WhatsApp message to Narasimhan to see if he had time to join in. So he and all of you could comment on that. So we get a 12-lead ECG, and all what you see over here is a part of the workup. And of course, if you can intelligently use genetic testing, you can use it to make sure that you're not dealing with genetically determined cause of VF, so that you can have more specific therapy, something like CPVT, for instance. So the way to sort of look at the big picture, stated differently, this is in JACC EP, we just published this. We invited Michel Hesseguer to contribute because he actually spent a lot of time collecting a lot of cases, literally traveling all over Europe to ablate these patients. So there is a phenotype screening, and then you go through detailed investigation for this. And if you can exclude all other causes, you have unexplained VF. And these are the ones where ultimately what you do is very careful mapping. And the hypothesis that has come up is there is a ultrastructural abnormality in the hypercondrial system and myocardial activation, which probably drives VF. So that is the sort of the working hypothesis. So when you say, when Ulhas gave the title as saying, idiopathic VF, I think all of us, and again, I would encourage, the teams in India, because I think you see more than anyone else in the world. So I think when you just read the literature, I would even read that with a little bit of a critical eye, in the sense, these are the words that have been written in a journal, but it's hard from being a completely established fact. Because the more carefully you look, many cases that have been referred to us over the years at UCLA with idiopathic VF were actually not idiopathic VF. They actually were focal inflammation or a subclinical version of a channelopathy, which was not adequately tested and identified. But having said this, there is a small, very small subset of patients who truly have idiopathic VF, because after doing an exhaustive search, we still can't identify a cause. So how does this whole thing now sort of fit into? So the big categories of what you would talk about as idiopathic VF would be conduction abnormality, repolarization abnormality, and excitation abnormality. And it turns out that this is the so-called substrate. You can't image it. It's completely electrically mapping derived definition, some of which you can pick on a surface ECG. If you see intralateral J-wave changes, which of course is a little bit of an overlap syndrome, right, in EP. And of course, you're dealing with focal Purkinje system activity that drives VF. It can be right ventricular endocardial or LV endocardial, as we'll see. So a word about pathophysiology. So as some of you may know, Giel Janse is a very close friend of ours. He's Hein Wellens' counterpart. He's the physician scientist at Amsterdam, one of the legends in EP. He's a close friend of ours, and he actually comes to UCLA once a year, and he spends a sabbatical month doing experiments. And I'm very fond of this because he's wearing our center's jacket. So Janse actually made a very interesting observation. And for the trainees and some of my colleagues in the audience, I would urge you to read this 1992 paper that he wrote he was, as you know, was the editor-in-chief of cardiovascular research. So Jansa actually talked about, what is the premature beat? And I would actually tell the audience and all of you that we still do not understand what causes a PVC, let alone fibrillation, which is another massive question mark. So I think some of the clinical observation that is going to be coming from many centers, and especially the group in India, I think we're going to learn a lot more. And I was excited to see the previous talk that there are so many technologies that are being created in India for large population use. So I think we're going to be learning a lot more. So this is an evolving story. So when you look at the big picture of arrhythmic death and sudden in apparently normal hearts, so we are dealing with sort of this tip of the iceberg and what is below the waterline type problem. All the J-wave syndrome, Brugada, long QT syndromes is what we can identify. What lies beneath the surface, and some we may never be able to identify, and there's still the search for novel genes and so forth, is the no phenotype. So it's a two spectrum. One is there is something in the ECG, something that triggers or makes you think of it, and then you have another one which is completely, truly idiopathic, and it's out of the blue, it's patient presence with sudden death. So there's a mosaic of underlying pathologies, which means what do you do for treatment other than, the patients were revived in whom they either come to you with an ICD or you're sitting in determining that you have to put in an ICD. So there are many possibilities over there. Ventricular ectopy with short coupling interval, long coupling interval, and also Purkinje system repetitive activity. So it's the first aspect of reading an ECG is, of course, you do a very careful review of the 12 lead, but you also pay attention to PVCs. So when you do see PVCs, and if you think the PVCs trigger VF, they give you some very important pathophysiologic information. They can be short coupled, long coupled, and the type of PVCs, there's another type of PVCs, which is variable coupling interval, and we'll talk about it in a second. The reason why they are important, of course, is the classic arrhythmia mechanisms, right? You have EAD dependent activation, delayed after depolarizations, and you also have the late phase, EAD, which is tachycardia pause dependent. So you have bradycardia dependent. Again, the coupling interval creates the substrate for these calcium abnormalities within myocytes, which are thought to be highly arrhythmogenic. So we have an interesting series of studies we did at UCLA, because the question to be asked is, why does this PVC make things arrhythmogenic? So this is a interesting piece of work that was done by David Heyman, who's now back, he trained with us and he's back in France. He's working with Nicolas Lelouch. He's one of the assistant professors there. And in fact, his professor was trained by us, Nicolas Lelouch. So David did this study where we did high density mapping of a beating heart. And we also directly recorded from neurons on a beating heart. Think about this. There are 15,000 neurons. You talked in the previous session about cardioneural ablation. This is the little brain of the heart. So this is the catheter sitting over here. And this is the multi-electrode array. So when you record from neurons in a beating heart, during each heartbeat, there are thousands of neurons. There are 15,000 neurons in the heart that are activated. So within a single heartbeat, there are 15,000 neurons that actually fire. And it turns out we can actually record from some of these neurons and interpret what the heart is telling the nervous system. So this is what costs millions of dollars to build the electrodes to make these recordings. And if you look at this over here in this little, it's a very busy slide, but I know that the teams in India love this. So here is the LV pressure tracing. And if you look at this histogram over here, these are neurons that fire just during the DPDT of ventricular pressure curve. So it's almost like a pressure sensor, right? So the heart is like this amazing engine that is wired by the nervous system. And later, you can actually classify these neurons and find out what it is that they're doing by doing physiologic interventions. And in this case, we actually experimentally gave PVCs at varying coupling interval, which is just an extra stimulus to the heart. It's like an S2, right? But the S1 just being sinus, this is like they are single S2s. And we actually did an analysis. And what David and Jason showed in the study was, and some of you may have met Jason, he's now an associate professor. He trained with us. He's been to Delhi at the India VT Symposium. So when they did the study, they spent a year and a half doing this research. So we were amazed by patients who came to us, referred to us with idiopathic VF, completely normal structurally, but all they had were PVCs that had varying coupling intervals. So the varying coupling interval seems to be very bad for the heart. So here's a human case example over here, varying coupling interval. So we now mimic this in the research lab. And what we found was, when you look at the sinus beat, and then you look at a PVC beat and look at the post-extrasystolic beat, having a PVC, especially a varying coupling PVC, has a profound effect on the heart's repolarization for multiple beats. So that's very important, okay? So if you get a PVC, it messes up the heart for many beats subsequently, which is one of the reasons why, even in pacemakers and others, we have a big paper that's going to come out, where if you have a PVC and if you get a second PVC, which is a R on a T wave of a PVC, it's even more arrhythmogenic because the rest of the heart has not recovered electrically. So why is this important? I think this has tremendous importance for completely normal hearts where you get VF. Now, commotio cordis is a classic example where you have it's an R on T on the chest that causes VF, right? It's sadly, a small number of people, they die because of chest wall impact. Mitral valve prolapse and sudden death may also be related to this. Of course, there is a structural problem over there, but this may be the kind of PVC that initiates it. And of course, as I told you, inflammation changes the entire milieu of the heart. Now, another model that we use to try to understand VF is inducing ischemia, because ischemia actually can cause a PVC, and that PVC can actually be mapped. So here's an example of high density mapping where we intentionally tie off a coronary artery. And in fact, we're now doing the correlate of this in patients undergoing angioplasty where you have transient coronary occlusion. But you can learn from this. So in these cases, what we did is, if you carefully map between the ischemic and the non-ischemic zone, it is the junction between these two zones where you get these PVCs that precipitously put you into VF, because you're now almost giving a spark, you're igniting a spark in a highly flammable region in the myocardium. The myocardium is now so unstable that this PVC, which is going to occur in that region simply because of the massive differences in repolarization, is the setting for the perfect storm. So that is and of course we can pick this up with T-wave changes, and I'll be happy to post some of these papers in the chat for people who are interested in reading it. Now, new developments are coming in the pipeline. Here is an example where we can directly measure neuropeptides and neurotransmitters, and you're going to like this, even without taking the blood or fluid out of the body. So we now have electrical methods of continuously measuring neurotransmitter levels and peptide levels. So we think that this is going to have a big impact. So in the near future, in your EP lab, just using your catheters, you can actually electrically measure the concentration of various chemicals in the heart. So we're now going to be able to metabolically map a heart and understand why some hearts are more stressed. And it's not just going to be simple electrical study, but you're going to get an understanding of the metabolism of the heart and what it's actually doing. So anyway, so that's enough on basic science, but you need to hear about basic science because, one day my dream and hope is it turns the field on its head, and there'll be some problems for which, hopefully someday large number of patients because of science may not actually need a pacemaker, but we may be having a different intervention for bradycardias, and of course, hopefully for sudden death, we'd be doing neural interventions and ablations instead of implanting ICDs. So management of idiopathic VF, of course, relies on catheter ablation. So if you have outflow PVCs, of course, you can very carefully map and ablate them. This is extremely well worked out. And, every time I see the IHRS postings and so forth, that, the teams, they're very, very, competent in mapping and identifying. So most of these fall into two groups, outflow and non-outflow locations. So I showed you two outflow locations. What about non-outflow locations? So the non-outflow locations typically tend to be within the Hespericular system. So this again is the beautiful McAlpine collection, which we are restoring. Soon there'll be an atlas. We're going to try to get this widely shared globally. This will be HRS, ACC, and IHRS. We're going to make many of this content available for the whole world because it took years to digitize this. So here's a beautiful example of the RV that has been opened up. And in McAlpine's beautiful anatomic descriptions, you can actually see that the moderator band and papillary muscles, all the areas where the Hespericular system conducts are potential sources for focal ventricular ectopy that can cause VTVF. So again, you're looking at this is a different cut section again, showing you the moderator band and the RV endocardial structures. And we now know that the moderator band is a source of PVCs, which we know for PVC ablation, but some of these PVCs can also trigger VF. Elad Anter and others have shown, and we've actually ablated 2 patients in our practice who had moderator band initiated focal VF. And again, the mapping of this is fairly straightforward. That's now the big focus of this talk. If you do have the pentarray, that helps with the mapping. And intracardiac echo, of course, helps with mapping so that you can identify the structure. The trick is always to get adequate catheter contact. And one of the things that we've observed, the same challenges all of you have, which is sometimes these PVCs are very finicky. They don't show up during when the patient is sedated. And the second thing is sometimes when you ablate these PVCs, they actually can induce VF during RF delivery. So that's kind of interesting because perhaps that also tells you that, you're potentially working on a region that has a very disturbed Hespericular network. So then, the other subset of patients who are used for or sort of subject to catheter ablation are patients who actually have the sort of the intralateral J-wave syndrome, which is the subtle ECG abnormality you see in the inferior leads. These patients, of course, have abnormal electrical activity, and this is the one subset where epicardial mapping perhaps is going to be useful and important. So you can sort of view this as a normal heart equivalent or near normal heart equivalent of ARVC type mapping. So this is another area that can be mapped and ablated. And based on our own anecdotal experience, by the way, the whole world's experience is anecdotal. There's never going to be randomized studies. These are rare cases. So we have been impressed by the fact that in some of these cases, you actually have very disorganized activity in these regions. Again, some of the cases in the literature, inflammation was not ruled out. But I can also tell you that in the handful of cases we've ablated, we've done PET scans, we've done biopsies, we've had normal voltage maps, but we've had PVC-induced VF. So ultimately, one comment at the end, many of these patients sometimes can present in VT-VF storm. And when that happens, our approach has always been to first stabilize them. And once you stabilize VT storm, sometimes you just see PVCs with non-sustained VT or just the PVCs. And the way we stabilize them, of course, is to use thoracic epidural or a temporary stellate block and beta blockers, of course. And once we do that, of course, we want to map and ablate them. There are a subset of patients in whom either you're not able to get PVCs or you don't have a substrate to map. You could potentially, in very select cases, go to the distal Hespericular system and ablate empirically. But we've been reluctant to do that. And in some of those patients, we'd rather prefer to offer neuromodulation. And that's where sort of the big impact of stenectomy, which the group in India knows very well. That's been useful for us. So acutely, we use thoracic epidural to stabilize the patient, or we can inject lidocaine in the stellar to stabilize the patient. And I know for a fact that there is an idiopathic VF case, and we've collaborated with Balbir Singh in Delhi, where he's actually done RF of the stellar too. So, but eventually, if you need to have permanent stellar block, it's doing the videoscopic approach for stellectomy. This, of course, is collaborative work with Yash and Amit and Narsaman, first published in Circulation in 2010. Numerous studies since then, and now it's an international experience, which actually shows in structural heart disease was the main group in it was used. But we've also used this for idiopathic VF patients, and those patients have done extremely well. And of course, to the extent we now actually have an entire team that is focused on this at UCLA. We have a nurse practitioner and an anesthesiologist who focus on that. And in fact, now 3 thoracic surgeons, not just 2, are trained to do this. And we are very actively trying to make this into an interventional procedure using some new techniques. And if that happens, perhaps there'll be a larger expansion of this method. So I'll stop here. Thank CSI, Dr. Pandarami, for this honor. And I'll turn it over to my chairs, Dr. Nair and Dr. Vora. And again, it's great to see all of you on Zoom. I'm looking forward. I'm even more anxious to be back home post-COVID so that we can meet again and get a cup of chai. So thank you so much, friends, and I'll turn it back to you.
Thank you, Shiv. As always, it's been a great learning experience from this small talk, and your work on, from cell to bedside, the translational medicine work which you do is just pioneering and path-breaking. So enjoyed the talk thoroughly well, and let me ask you this question. You very rightly pointed out that this focal inflammation, probably we've been missing this, and that may be a cause of VT-VF and sudden deaths. The question is that, what is the size of the inflammation? Does the size matter at all? Does it have to be few millimeters, few centimeters? Because we do cardiac MR, and now quantification of the scarring is being done. What is the quantification which can lead to a VT-VF? I mean, it is an extremely insightful question, and we've always wondered about this, right? So, is there a critical mass of cells that have to be inflamed to cause this? The answer is not known, and the biggest limitations for that, Amit, is the fact that PET CTs, right? PET CTs are very nice, but their resolution is not at the level of electron atomic mapping. So I think that's, and we've seen some cases where the PET has been equivocal, where there was a subtle, increase, and they're not able to clearly say that there is myocardial inflammation. The easy cases are where there is a hot spot, and you can say, roughly, that region. And the hot spots also are very hot at the center, and there is sort of a penumbra, if you will. But we don't have a sort of an idea of how much myocardium. And I actually suspect there are some cases where there is actually even trivial inflammation, and we don't have the techniques to pick them up. So in fact, one of the biggest studies that I've always been amazed by in the literature comes from 1979. And in fact, I'll even show this for the audience. This is one of the advantages of doing this meeting in a Zoom format. I projected this, and many of you can see this. This is 1976. Thomas James and Doug Zipes published this, Amit. And if you look at this particular study, this actually had young women, idiopathic, structurally normal hearts. They died, and the only abnormality they could find was ganglionitis, inflammation of neurons on the surface of the heart. So this is very eye-opening. Think about this, right? This could not have been picked up by PET scan. So I have a feeling that if today, if the key groups in the world, pick these people, and if we actually go back and revisit this literature, I'm hoping that,
look at this 27-year-old woman. These are the kinds of people who have died. And this was yesterday at the NIH, the workshop, we made a very big point of this, and I pointed this out to the world, because I really think that, if 22 people are dying every minute in the world, and many of them don't have structural heart disease, maybe this is the target we should be looking at, which is upstream. Who knows, everything from, pollution, living in Delhi, and Los Angeles is not far behind Delhi in terms of air quality and pollution. So it's these kinds of things, who knows, right? So I think ultimately it's basic science meets epidemiology. And I think we are probably seeing just the extreme cases, and even these cases of these localized abnormalities, we happen to pick that up. But perhaps if we map more people, we'll see that the body is reacting to something environment, right? So I'm curious to see what others think. We've found that some cases electroanatomic mapping is more accurate. It can pick up small areas of electrical signal abnormality which the PET scan missed. But again, I often wonder, should we be ablating them instead of giving them a short course of immunosuppressives? So it's a great question, Amit. It's a great question. I'd love to see more answers, and as we learn more, we'll bring it to you too.
Right. The last point you made, sorry, Mon, can I make one more?
Yeah. Go ahead.
Sorry, one more last question, Shiv. That, the last point you mentioned about ablation and the role of Purkinje PVCs in idiopathic VF. And we also know the extensiveness of the Purkinje system. Now, do we truly have a handle that the Purkinje PVC is only a trigger, or is there a microstructural abnormality which leads to this? Because, when we are ablating, one tends to worry that you may take away one trigger. What about the other triggers? Next day, you may find triggers, Purkinje PVC from elsewhere.
It's a great question. And I'm so happy you asked that, because we've actually seen two subsets of patients. We don't have enough numbers to make the case. Some cases, we've actually had PVCs coming from a region of the Purkinje system. We've ablated it. Patients have done well. So we say, khatam, that's done. Patients not getting shocks. We are not getting called. So that's our endpoint. But then, and those patients, interestingly, that subgroup of patients, nothing else has happened. And in fact, some of them do so well. They're coming and saying when the device battery has to be changed, they say, "Oh, doctor, can you take this out?" We're like, no way, we can't recommend that, especially if they've been aborted sudden deaths. There's another group of people, and we've actually seen that in people who've abused methamphetamine, a little bit hard to say, but they actually have multiple, PVC triggers, Purkinje triggers. And in fact, one of the most remarkable cases was a patient who underwent 3 Purkinje VT PVC ablation for VF in our experience. And that was the very first patient in whom, in 2012, we did a bilateral sympathectomy. We did a left stellectomy. The patient was still having VT-VF. And after that, he was taken in for the 3rd ablation. He had 2 VT ablations, record with a different Purkinje PVC. We said, let's do a left stellectomy. Patient then recurred. This patient was in the hospital for 30 days, and then out of sheer desperation, we did a right stellectomy. And of course, after that, he didn't have a single PVC. And the patient's EF, which was 20, normalized. And the patient now, we have a 9-year follow-up. He refuses to have an ICD. So that actually different areas showed up. So that makes you think that it was functional and it was completely, sort of autonomically driven. Now, the third point, as an extension of the question that you asked, is we're ablating the Purkinje system. We're also we're messing up things over there, right? Could it be proarrhythmic? It's not proarrhythmic in other patients in whom we ablate endocardium, obviously. But is there something different in these people where we go and ablate the Purkinje network? Are we creating a small nidus for a future problem? That is also there. I think that risk is small, but it's still a little bit of a concern in the back of our mind. I think it's good that we don't have very strong technologies for ablation in the ventricle. Otherwise, like post-fib tachycardias we see in the atrium, we probably will be seeing more proarrhythmia from the ventricle. But it's a great, very insightful question, Amit. Thank you for asking that.
Two things, Shiv. One from Amit's question and your comments. Our limited experience and the way we discuss in IHRS, when we strictly look at young patients with idiopathic, no or nothing seen on MRI, I'm not sure they're all been PET scanned, and nothing much on the ECG. They seem to be doing very well with, and you identify a PVC. My own experience and most of the others that I talk, you ablate, you do give an ICD because you don't want to have a VF again. But a good number and majority, I think, do not use their ICD. So is there a chance that the more you investigate and qualify them as idiopathic, the ablation is likely to work more?
The answer is absolutely yes, Mohan. In fact, you know this. You were at the India VT Symposium. We are now following some of the patients we ablated in New Delhi. I'm amazed that Balbri's assistant, and I hear from you and our colleagues in India, the follow-up is so extremely good. Lokanwala knows every patient is ablated, and he knows the neighbor's name, and he knows the car driver's name. I mean, he is the level of follow-up. I don't know. Someone has to get a readout of Yash's mind and how it works. So again, that level of follow-up. How it is. I get it because we are all very closely linked culturally to our patients and the way we practice in India. I think that follow-up is going to be important. And one contribution that IHRS could make, and in fact, we now have the resources where people can put this information together. I think that is going to move the field forward. I mean, for sure, I think those patients, that is the first category I told you, they're doing well. In fact, one of them comes and says, please take out my ICD. We say, we don't have the guts to do that. We are bold, but not that bold, But again, it's and I think it's safer to actually have ICD as a backup. But it's still, from a patient's perspective, you're worried now. It's 15 years later, lead fracture, all that adds up. It's going to be. I think this is why I would strongly encourage. All of you are so amazingly busy. Even if you carefully track these cases, I think it'll help all of mankind because. In China, the follow-up is more complicated. If you actually look at, we have close friends there, we work with them and we see how they follow up. I have a feeling that this type of a long-term follow-up from your individual practices, I think it's going to have a big impact. And I would use this opportunity to, again, mention to all of you, Ulhas, when I talk to each one of you one-on-one, I know this, but please do collect them together because we have to find a way to bring this to the literature because if the work that many of you have done were not published, I could easily say that the field would not have moved forward at all. The stuff that, as at the start I said, what you, Amit and Yash and Narasimhan have done and the amazing teaching that Ulhas and the teams do, these things matter a lot. And I was really looking forward to this opportunity. So thank you for asking that question, Mohan.
Among the people that I have worked with and I know in India, Amit is the best guy for a registry. He is very good at handling people and he's done a lot of them. And maybe it's a good opportunity to start off. The second was more mechanistic.
Yes.
I think I'm sure Amit will do it. He's got the energy to do it. So you see the AFib registry and the beautifully done. Now, second is more mechanistic. Seeing one of your slide, it was a very nice but also a little scary about what happens with the PVC and the sinus rhythm following that.
Yes.
So potentially every man is a potential candidate for VF, right?
Yes. It's as they say. It is exactly like the part of the Mahabharata where Bhishma in the Shanti Parva talks to Yudhishthira. He says, a man is surrounded by many, many, many ways in which you could die, but still it's a miracle that sometimes we manage to live. Some of you may know what I'm talking about. It's the analogy. It's a very long part of the when he's giving the instructions to Yudhishthira on his deathbed of arrows after the Kurukshetra war, right? He talks about a man running through a forest in the middle of the night. That analogy, it is amazing. You know, I've actually made a slide of it as a description of all the risks and how, you know, what is the risk factors for sudden death. We are surrounded by it, and you're right. It's all about a very critically timed PVC. It's almost like, you know, when multiple things line up, you get the perfect storm. But what is more miraculous is bulk of PVCs don't cause VF, right? It is the reverse. So sinus rhythm is the miracle, you know.
Yeah.
There are many reasons why you should trigger and go into VF. It's amazing that, you know, life continues.
So would you somewhere in the near future change your slide of evaluation to include some assessment of neural axis, cardiac examination?
Yeah, well,
you all just do an EEG, for example.
Yeah, yes, it's actually a great question, Mohan. There are two opportunities that have come up. One is invasive. Now, the invasive testing is we can actually, you know, record from, you know, cardiac neurons, stellate and the cardiac. In fact, near the fat pads during an EP study. The other area where you can actually do a recording comes from fMRI. So it's a kind of a link of two worlds, if you will. And what we have been, you know, amazed by is you can actually do an fMRI and exactly image the part of the brain that is activated when, you know, you can classify people into people who are sympathetically hyper responsive to people who are a lot calmer, if you will, you know, so they don't.
I'm extremely sorry for the interruption. We are almost coming to the end of the session, sir.
Sure. Thank you, Rachna.
Thank you so much.
No, thank you. No, what it is the amount of catechol that is released. Ulha, sorry, go ahead.
Yeah, sorry. You know what? We need to be respecting the digital space and digital.
Yeah, of course.
Okay, it had been wonderful. You know, I'm so very pained to say that, you know, this Cardiac Rhythm Council 2020 of Cardiological Society of India meeting is coming to an end. You know, I wished it went on and on and on forever. In fact, it has been going on for the last one whole week. Several complaints from my colleagues that their family members are objecting why this guy from 6 o'clock till 8 o'clock or 9 o'clock. And today was the longest of the sessions in the last 6 days. We exceeded more than 1 hour of the allotted digital space at the time. But
oh my God, I sorry about that.
No.
Nobody
on and on.
Noticed that. Nobody could. Everybody was immersed in the way you taught us this concept of idiopathic VF. What I take home, and probably the audience would know, there's nothing like idiopathic VF, or there's nothing like idiopathic. Idiopathic stands for ignorance, or our inability, or our limitations to find out what exactly in it. I think that was the greatest of the message on this Teacher's Day from the greatest teacher, Dr. Kalyanam Shivakumar, you had given to us. You had been always very supportive of the EP education in the country. We look forward to the collaboration with you and with your team. You're always proud of your team. Every time you show the first slide, you know, it inspires us. How do we go about the teamwork? Thank you very, very much. I know that it had been really painful for you to be accommodating your time. Thank you very much. And
no, the least I could do. Thank you so much. And all of you enjoy the rest of your day. Thank you so much for taking the time. Bye-bye. Thank you. Thank you, Amit. Thank you, Mohan.
Thanks.
Best to your families. Be safe.
It's in the neighborhood.
Yeah. Thank you, Aparna. Take care.
See you soon in person.
I know. I'm looking forward to that.
Right. So, Acha, by the way, a few announcements to be made here. Looks like this is one of the most successful webinar series that the country had seen in this COVID era. Every day we had more than 1,000 registrations. That itself is a big achievement, and it goes to Indian Heart Rhythm Society, Cardiological Society of India. And I think at any given point in time, in the last, 2 hours during the last 7 days, the people who are actively involved was touching 300. According to the sources, this has been wonderful. And it was all possible because of Indian Heart Rhythm Society members and the Cardiology Society of India members. It was an honor for me to be hosting this on behalf of them. And thank you very, very much. And here, there's this conclusion of the Cardiac Rhythm Council meeting. Thank you, everybody. And
very well done, Ullas. Very well done.